I'm Dr. Marsha Sanity,
And I'm Dr. Caleb Moore,
and this is
the
the
Free
Free
Smiles
Smiles
Podcast.
Podcast.
So today we are discussing dental implants.
The beauty, the grace of dental implants.
I'm very excited about this topic. I feel like you and I have dedicated a lot of CE to dental implants in the last 2 years.
A lot.
A lot of time.
A lot.
But we started out just working, I think it was with Neodent. That
Yep.
was one of our first
Yeah,
courses.
that was the initial. At this point, it's just interesting how many different dental companies there are. Just at the course that I was at last week, that, we touched on dental implants as a holistic part of things, but just how different implants, even though they're made out of titanium, there's all these other, like, each company has their own formula of other things they put in, and it's just, man, it can get real interesting.
Technical, right?
Yeah. So yeah, nerded out a little bit about, dental implants just recently. So yeah.
I want to start with risk assessment for dental implants and, case selection. What are we looking for in patients who may be a good fit for implants and people who may not be a good fit?
Yeah, let me think about who wouldn't be. I think that's the easier one to rule out.
Let's start with who wouldn't.
And it's really not that it's a total, like, you're out of the game completely with a few of these, like, I would say systemic things or big things that we think about or look at, because in any kind of surgery where we're putting something into your body, is your body going to respond to that well? So the biggest things we look at are, what's your current, do you have diabetes? Diabetes is a huge risk factor, and so is smoking. I think those are the two kind of biggest red flags.
Yes.
I think smoking is probably higher up on that, at least from my understanding, the doctors that I've learned for, the MFSs I've worked for. And it's because it truly is like a high risk for failure. And that's where I think I look at when it comes to doing a dental implant is, what's our risk for this not lasting, the predictable amount of time.
Right. And I think people who smoke, I guess the process behind that is vasoconstriction, right? So, areas in the mouth, they aren't receiving the nutrients that they need, which is going to affect osseointegration, and it can even affect just the health of the implant long term, right? If they had an implant placed when they weren't smoking and then they become a smoker, right? What does that look like for the implant 5 years later? It has to have the nutrients.
Yeah, for sure. And I think part of this conversation, not that we have all the information on it, but talking about, how does vaping come into play with that? Because there's a lot more people nowadays, and this is a whole nother probably topic of conversation to go into at a later date, but people who vape, I mean, your intake of nicotine is, you're still intaking nicotine, and it comes with chew, it comes with, what's the new one? Zins are like that new tobacco. So there's not a lot of extra stuff into those. So they're not as, I shouldn't say less harmful. I hate like even putting that out there, but they're less like caustic or abrasive to the gums and things like that. But there's still that change in your vascularity that nicotine does bring to the table. So no matter what we do, if you're smoking, you're vaping, you're a nicotine patch user, whatever it may be, that intake of nicotine is going to decrease vascularity. It just obviously in certain instances increases other risk for, other things like oral cancer and things like that. But vascularity is huge. If we don't have that, then we don't have bone growth and things like that when it comes to the actual healing process. You'll heal less effectively, which is, it's a non-predictable thing sometimes how someone's going to heal, but we do so many things to try to make that healing process the best. And, we always want the best outcome for our patients. We don't want to have a patient invest into something time, energy, and money wise that's not going to give us the predictable outcome.
Yeah. And I think having people, even I have a patient who's considering an all-on-X right now, and his, dental health has just rapidly declined over the years. He hasn't been to the dentist in over 10 years. But he also hasn't seen his primary care in 10 years. So, and he's also a smoker. So it's a very, I'm very hesitant to start this process for him or even give him the green light. I'm like, there are things that you need to do beforehand. We need to talk about smoking cessation. I need you to go get labs. What are your vitamin D levels? What does your blood work look like? Your glucose levels, your blood pressure, all of these things, they're all factors, which we all know about and we've discussed in earlier episodes. But I think when it relates to dental implants, we have to put that like at the front of everything, right? Because we could say, oh yeah, this tooth, it's time to go, but is that implant going to osseointegrate, and is it going to last, 10 to 15 years,
Yeah, exactly. Or even longer. I mean, our hope is
Right.
that the dental implant lasts, for the remainder life of that patient. So
Absolutely.
age is a huge thing, I think, that we look at when it comes to deciding on whether or not it's time to do an implant. Like
Mhm.
one of our previous episodes, we talked about root canals.
Yeah.
So when I'm looking at a patient and I'm saying, hey, this is a front tooth, let's say, and it's a young patient, I'm not just going to be like, oh, let's take this tooth out right away
Yeah.
and do an implant, unless that's,
Right.
The option if it's, a non-restorable tooth at that point. If there isn't enough tooth to restore, then we're like, hey, let's talk about implants, but then we have to plan so much. So
Mhm.
I think that's a huge thing to discuss is the planning for those anterior like aesthetic zone. I'm working on a really
Yeah.
big case right now when it comes to that we're doing clear aligners. She has existing veneers that we're going to be replacing
Yep.
after the fact. We're doing an immediate implant placement with provisionalization and then moving her teeth and then finalizing everything.
Yeah.
So imagine my distress.
Yeah, right.
Not distress, but really trying to get a patient to see the full picture.
Yep.
Because yes, this tooth is failing. She already had a post-in coronet. It's already had an apicoectomy done on it.
Right.
Now the crown is fracturing off and it's
A Hail
mobile.
Mary,
It's
right.
number 10. We're not. She just got into a new relationship and she's
Yep.
like, I cannot have a front tooth. So, I'm trying to give her that doing an immediate implant. So
Yep.
trying to coordinate that, but also if we can't directly provisionalize that tooth that day,
Mhm.
we're going to be using her aligners as a temporary,
Right.
painting on that until we can get a few months out so we can actually put a provisional there. So there's a lot of coordination with that as far as patient understanding, my expertise in understanding, me
Right.
coordinating with my lab, me working with my surgeon,
Yep.
my periodontist that I work with. So, I mean, it's cool. It's a very cool thing that we can now take all these different things with technology and give a patient the best outcome. But yeah, it's a whole thing. It's
Yeah.
never simple.
No, it's never simple. Even the ones that you think are simple, when when I was interested in learning more about dental implants, I had a mentor, a periodontist, who was like, it's not about placing the implant. That's not what learning dental implants is about. It's about managing the complications that are going to come when placing or after it's placed. If we can handle those complications or be prepared for them, it's going to minimize the failure rate, and that's what we're looking for. So I think whenever you're planning those cases, we have to look, is there enough buccal bone, especially in the aesthetic zone, right? What does their gingival tissue look like? Because ideally, when you're placing those anterior implants, you want it to be, 2 millimeters subcrustal, right? Or from the gingival margin, no more than 4. If it's too deep, then they're not able to clean it. Then cleansability goes down. And then we also have to consider the gingival papilla. How is that going to recontour? Something that you had mentioned, provisionalizing the tooth, is really beneficial. And if we can get enough torque to be able to do that, that's going to allow the tissue to heal the way that we want it to, right? And so that way we can have the end goal in mind, which is huge.
And I think I do think like the way we learned implant placement when we were in school, like the kind of baseline of understanding that, it's always about being prosthetically driven,
Hmm.
which I think like in history, when it comes to dental implants, it was like, if we can get an implant to fit, this is where it's going.
Yeah.
Like that's how it used to be. And I think it's a very amazing kind of transformation that we have but it's a lot, you have to know a lot about prosthetics, about restorative, about tissue
Hmm.
contouring. All those things had to come into play. And I think a lot of our training over these past few years has been about immediate implant provisionalization,
Right.
because we know that that's the best outcome for that patient, especially if I'm in like a premolar, anywhere a premolar forward.
Hmm.
I'm almost always going to be like, we need to provisionalize this, if not that day,
Right.
as soon as possible because of that tissue contour, so we can make that tooth look as natural as possible. So if anyone is walking past that person, that they're smiling, if you're in a photo, you don't notice that tooth looks any different.
Yeah.
And the same goes for any crown that we do in that. We're trying to make things look as natural as possible.
Yeah. And I think about a case that I was working on almost a year ago now, but I had a patient who had come in he had lost 8 and 9 and had been in this flipper for, it was a long time, maybe like 6 to 8 months, due to finances and not having trust in the provider who was previously seeing him. And, I think for patients, it's really important to do your research on providers, because there are some providers who will just send it to the lab, be like, do this for me, right? Like, I just want implant crown on 8 and 9. And, the reality is the less that we communicate with our specialist and with the lab, you know, that then the quality of the results, it goes down. So when he had come to me, I'm like, okay, well, this is definitely going to be challenging. So number one, we set expectations. We had a consult. I explained to him that 2 implants next to each other, the tissue is not going to be, the papilla is not going to be the same as what 2 natural teeth are together. Showed him a little diagram that I found online. And we just sat down and discussed it. And he was like, nobody ever explained that to me. So immediately his expectations were, I know that you can make this look good for me, but it's never going to be the exact same, right?
Well, yeah, for sure. And that's because not only are some of those things unpredictable, like obviously when we know about placing implants and trying to do something like an immediate provisional, the reason we're doing that is because we're trying to get that papilla to grow up and to look natural.
Exactly.
But if someone comes into your chair who is already missing that tooth, that's probably one of the hardest aesthetic things that we can do, is try to make tissue go where tissue hasn't been.
Yeah.
And where there's nothing supporting that tissue where bone used to be, where now it's flattened off. And I know what case you're talking about, which ended up being a really beautiful result.
Yeah, it was a really beautiful result. But what I did is I had actually texted my lab tech and I was like, hey, these are the goals that I have for the patient. Is there anything you can do with the current models that I have, from the previous lab that tried these, and I showed him what they look like. They look like chiclets. It was terrible. And he was like, send them my way. I'm going to send you back something, just like a provisional that you can add to. So he came in, I actually removed the healing abutments, tried in these provisionals, and we lasered the tissue. I added flowable to the sides to give it more of an emergence profile. And it actually, I let that sit for, I said 3 months, but it ended up being like 6 months, just because he was really happy with them, right? Which is always a good thing.
Yeah, for sure.
But then he came back in, and that papilla had come down, probably 80% of the way that we had hoped.
Yeah.
But he was in love with them, and it was a really rewarding case. But like you said, a lot of planning, knowing what the end goal is and what you're looking for, and then setting expectations, and that was huge. But yeah, I mean, that was a beautiful case. I was really happy about that one.
Well, and I also think, like you saying that, I think people, maybe the general population, or maybe, doctors as they're first getting into this, is they overlook that provisionalizing part of it and how important that is. Like, your provisional is more important than your final crown, in my opinion, as far as the shape, the color, the contour. Because not only is it giving you the tissue contours that you want at the end, but it's giving your patient confidence in that process, which is worth more than anything. Because a happy patient at the end of the day, someone who's leaving your office and they're temporaries, like this is like with an aesthetic case, I'm doing veneers, I'm doing a full smile, whatever. Their veneer provisionals or their veneer temporaries that are on there look amazing. Then I know they're going to be really happy with the finals, because obviously the finals are going to be glossy and porcelain and, have all those different like colors and things to them that kind of make them look even more natural. But it's just such a, I think, overlooked thing that I think we're, hopefully getting people more excited about doing provisionals.
Yeah.
And we have to charge for that. Like, it's not something that we don't charge for. Like, we charge for a custom, whatever, provisional, what's it called?
But yeah,
abutment or whatever. Then we it's like it's not like it's a free thing that's just part of that, because it takes time in our chair and it takes all those things. So I think just understanding that investment into implants, especially a nice, beautiful end result, is an investment. Yeah.
And having those conversations with patients. I have another patient, I've been working with her for a while, and one of the things that you and I talk about is like, what we love to do here is talk about our failures as well, right? Because I went into her case with the idea that I was going to use a guide and do it guided, because it was number 9.
Yeah.
And I was like, this is daunting. And
I actually stopped doing guided, I think, after this story.
Yeah. And
not that I stopped doing it, but I got more into my own instincts and
Right.
feeling
Yep.
because a guide should be there as like a secondary thing,
Right.
not the whole thing.
Not the whole
Yeah.
thing, right?
And sometimes it can be, but anyway,
Yeah.
I know. Yeah, go ahead.
So, I mean, yeah, and it's like one of the 5 human truths or whatever they say is like we want to be in control or like be in control of what's going on or the outcomes in life, you know? And so I had this guide and I put my trust in it, and you know, there ended up being a buccal fenestration. And clinically, I mean, was it acceptable? Maybe, right? But I wasn't happy about it. And you know, the patient, you know, I spoke to her about, you know, the bone wasn't, you know, where it should be in that area, the guide, and it was just not aligned where it should have been. So we're gonna go in. I redid it for her at no charge. But yeah, I mean, technically, was that a failure? Yes. I know we sit here and say, well, we have many failures, but really it's not a failure, it's a growing moment, and everyone's bones different, their anatomy is different, and it can be very technical in the aesthetic zone. So I decided to go ahead and do a flap, place it, you know, free-handed, and the whole point of this is at the end of that, it's healed up very well. It looks gorgeous. I'm really happy with it, and we're finally at the stage where we are you know, putting the restoration on. So I had spoke with her about options. I'm like, your tissue, she actually has a really good tissue. But I'm like, do you want to invest in the provisional? Here are the benefits of it. I would highly recommend this. Or would you like to go straight to the final? I mean, you have good tissue, but there's always a chance that it may not come out the way that we want it to without testing it out first, like, you know, test driving a car, right? And I also said, you know, I can take photos, I can communicate with the lab, I can use a shade tab, whatever you want to do. But there's also an option to do custom shade matching, and we have a local lab that I would recommend doing. And at the end of the day, I educated her on all the options, and she's like, I would just like to go for it. Like, I'm really ready to finish the process, and I'll pick out the shade with you. I'm just ready. And so, you know, for me, is that the way I would have wanted it to go? Maybe not. But at the end of the day, it's about meeting patients where they're at.
Right.
And she's going to be really happy with it. And I have a really good lab, so I'm excited for it.
Yeah.
But I also think that was an important case to highlight because it wasn't perfect from the beginning. I didn't go in and think, I'm going to place this implant with this guide. It's going to be great. No, I brought the patient back afterwards and was like, look, this isn't ideal. The placement wasn't ideal, and we need to redo it because I want you to have the best result. So it's going to happen.
Well, yeah, and that's just, I mean, that's part of our line of work is being able to assess what we've done and be like, hey, I don't like this, so I want to redo this, or, you know, whatever it may be. And I think that's just part of just being a good provider. And there's obviously like certain things, you know, that I think patients expect, like, oh, I had this crown done 10 years ago and now I have decay around it.
Right.
Okay, that's not something that I'm just gonna, you know, hey, I didn't do the crown. But, you know, there's certain things that I think there's a patient expectation of what we should be redoing for them. And there is a window of what that means.
Yeah.
And follow-ups and things like that and communication. But I think there's also a huge part of taking those moments and knowing I could be doing this for 10, 20 years and I'm going to have this moment come up again because of X, Y, and Z is not always predictable with those things. So, and I think just, you know, kind of kudos to yourself and any doctor out there that's like, hey, I stand behind my work. I want this to be better. And, you know, having those tough conversations with patients, because it is hard to be like, hey, I didn't like the way this turned out.
Yeah.
Let's do it again. If you go in for a knee surgery and it doesn't turn out well, they're going to charge you for that second knee surgery.
Exactly.
You know what I mean? I think in dentistry, we do a lot of what we would say like free work or work in that sense, because we do. We're at the core of us, we're artists and we have pride in what we want to do. And we want that to be a good outcome. We want it to be a good experience for our patients.
Yeah. I want to focus on why implants are even relevant and why they're important to consider in a treatment plan. You know, because some people, they think, well, why can't I just do a bridge, you know?
Yeah, and I think, I mean, whenever I'm presenting a case, I'm always giving that as an option for a patient because I think they should have all the information. I think they should have the option to do nothing. I think they should have the option for doing something like a bridge or an FPD or a removable prosthetic, which is obviously, you know, everyone has the choice to kind of make as long as they're informed. I think the downside, so there's always the the caveat of, okay, what's the long-term cost of this?
Yeah.
You know, it's almost like when you go and you put a cheaper part in your car, you know, you're going to have to replace it down the road again or whatever it may be. So up front, most of the time, if you have a small enough space, it's not a long spanning bridge, the predictability of that is, yeah, this will probably give you about 10 years max.
Yeah.
Because of recurrent decay, hard to clean, periodontal issues. So that bridge up front, by the time you replace it a second time, is going to be more than it is to do that implant.
Yeah.
Because of you're doing something twice, you're also prepping the teeth around it. So in order to get a bridge to sit or fit properly, we had to put crowns on the teeth around the space. So then we're risking, okay, what's the situation on the tooth behind it? Does the tooth behind it also have a root canal?
Yep.
Is the perio involved? Is it in an awkward angle? So now the root torque's going to be a little bit funny when it comes to this patient's bite now being forced to be mostly on this tooth, but then a little bit on the tooth in front of it. Like all these things are just almost like engineering nightmares. Like if you think about it, like I think about anytime talking about a bridge with a patient, I'm thinking, okay, what's the prognosis of this after 10 years? And if it's really low, if that patient doesn't have great hygiene, they have perio issues, I'm just like, I really think we should talk about, you know, an implant option for you.
And the misconception is that, well, I don't want to do an implant because it's really invasive. A surgery sounds too invasive for me. But the reality of it is if we choose the bridge, that's really invasive.
But and you can't get back that enamel that will take off when we're doing that bridge prep.
You're prepping the teeth around them. You're losing all of this tooth structure. That is arguably more invasive than drilling an osteotomy that you could do with a drill punch, you know, into the tissue.
Oh yeah.
So
you don't even have to flap it.
Exactly. So it's really just communicating that with patients because there is a misconception sometimes. But like you talked about, cleansability and then also structural support. So how is that bridge functioning, right? Because then those teeth are taking the stress. Eventually they're going to need root canals, right? And then when we get 10 years down the road after we've root canaled both of them and maybe replaced the bridge once, now the bone in between where we would have just placed the implant to begin with has resorbed so much and the tissue has remodeled that it's not set up for success anymore. So if we know the end goal or we know the prognosis is like we're eventually going to be going towards an implant, and then, you know, why would we do the bridge to begin with?
Right. Yeah, I would rather have a patient have the tooth out, do that. I mean, doing bone grafting at the time of extraction, that is probably one of the most important conversations I think I have, is because even if someone's not mentally ready that day to do an immediate implant or have that implant placed, I want to set this site up for success for that when you are ready for this. Exactly. And even if it's placing, you know, doing the bone graft, doing the membrane, suturing that up, and then maybe having an S6 retainer made so then we don't get shifting of the teeth around it or something, you know, or let's do some Invisalign or let's get the rest of the teeth straight. Now that we have a little more space here, I mean, when we remove like a number 19 or a mandibular molar, it's a huge space.
Yes.
So if we're just putting in one implant there, the contour of that is also going to be much bigger. So maybe we should close that space a little bit with some ortho before we're ready for that final implant. And that gives us a little more time as well. So again, it's like you really had to talk to patients about all these different factors. Like I have a patient that's came in for a limited, I'll see him soon just to kind of like finalize our plan, but he has 2 teeth that have resorption. Fun fact, Lyme disease and autoimmune issues are linked to increased resorption. So we're seeing a lot more resorption now with patients because there's an autoimmune component to that, if you can imagine. So 2 teeth that have had resorption, non-restorable, like perfed out to the bone. The tooth's about to, you know, probably fracture any day now. So we talked about he has a lot of crowding. He's always wanted to fix the crowding in his lower front teeth. One of the teeth that's resorbed is number 25, so lower front tooth. I'm like, hey, let's get this guy out of there.
Yeah.
It needs to come out anyways. It gives us space. Let's move the teeth, get your bite set up. Yeah, his midline's going to look different on the lower because we don't have a central, but no one cares. It's not like it's, you know, that big of an aesthetic thing for him.
But you set the expectation of this is what we're doing. And
yeah, exactly. Yeah. And then we'll prepare that site. So we'll it's an upper molar that has the other resorption. When we take that out, grafting it, getting the alignment right, I can close that space a little bit. So then his final crown isn't this honking crown that's going to be in
Right.
this, because he has like big molars. It's not like a tiny molar guy. So it's really just exploring those, like, I think fun conversations with patients about, hey, what are your goals? Like, what do you
Yeah.
want out of your smile? And if we can play with some space here and actually allow for us to get a better bite and success, then we're also going to set that implant up for better success. I see so many implants that are restored that they're not in occlusion. They're just so below because the doctor that, was seeing them was so afraid of how traumatic their bite was for
Right.
that implant to fail because they just didn't want it to touch it at all.
Yep.
Which then it's like, so what's that implant? You know what I mean?
Yeah.
Like what's, so, and there's compromise. Not everyone's ready to go through all of that, but it's so much more, there's so many more layers. Like the more we learn and the more we know about this, that no conversation's really like a simple conversation, you know?
One of the components that I think about is the financial aspect of it, because patients have this idea that implants are really expensive. But if we talk about the different ways that we can place an implant, they can invest in it over a period of time. So if we start with just a simple extraction with, atraumatic extraction with socket preservation, bone grafting, membrane, you're investing in that now. Then you have a few months to save up. Then you're paying for the surgery, right? And then, a few months, and then you're paying for the crown. So it can actually be a very, easy way to save money along the way, so that way they can make it affordable for the patient, because in the demographic that I'm working in and doing a lot of implants where there's a need, that is a huge concern. And along with that, I have this patient who is considering All on X, and he's like, I can save this much money for a month to be able, because it is a huge treatment plan, right? This is a life-changing treatment plan, the price of a car, right?
Yep.
So he's like, maybe for now we, and I kind of guided him through this step. I said, one of the options could be we extract the teeth now, we bone graft, we membrane, we get you in some interims, right, that you can heal in.
Yep.
It's not going to be fun, but we could keep the lower front teeth that are stable for now. We'll do SRP on them, do like an interim upper and partial on the lower. We'll bone graft everything, and then you have a year to save, right? Because after a year, that bone will start to resorb.
Right.
But in the meantime, it gives him time to plan for this. And yes, doing a 2-stage surgery, is it the best? No, but it's what's going to work for him.
That's what's going to work for the patient. I think that's a huge part of it is, we work in this field because we care and we truly want to help people. And I think it's tough to have a one-size-fits-all approach to things because it's never the same. Like no two patients the same, and no two patients are really ready. It's a huge conversation. Like an All on X case is, it's a big surgery. Like, I mean, it's managed well, and we do everything we can to make it like atraumatic for the patient, but it is like losing your teeth if they're failing, if there's all these issues going on, like just the mental part of that and just planning the financial parts of that. Like you would say most 90% of people have to financially plan for something like that and really like save up for it. So I think that's a huge, actually I have a patient coming in, whenever his new patient experience, he's coming in, I think this month for his consultation with myself and my surgeon. And he has full mouth crowns and some fractured lower teeth, and all of his crowns on the upper have recurrent decay.
Yeah.
So it's that hard conversation. He's in his 50s. So 50s, maybe 60s. And I was like, hey, it's been X amount of years since you've been to the dentist. You have all this work done. What's your goal? And he, we went through his diet, we went through his nutrition, we went through all these things. And he's like, he's kind of exhausted, like going through a full arch of work and then having that, maybe it lasted 5 or 10 years for him. Obviously a lot of that's on the patient, the diet, saliva flow, all those things is on the person who did that work.
Right.
But going through another, like I'd had to do another full arch smile design, and the cost of that arch of redoing all of those in my practice is about the same of doing an arch of an implant supported like All on X.
And what's the prognosis going to be now that there's recurrent decay under all of those crowns?
Yeah.
You get in there, you go to cut off these crowns. What tooth structure is left?
And time for that patient in the chair. I mean, that's a full day of prep, obviously you prepare, you take scans, you get the provisional, but like prepping and the exhaustion, like he's been through so much dental work. If we can really navigate, like you're going to be sedated, we're going to do the surgery. Yes, you might not get immediate like fixed prosthesis that day, but over the next couple of months, we're going to get you like prepared, get you some, temps, and then get you into the final and not have to, with obviously you still have to have good home care. Like there's all those big conversations, but it's going to be an interesting case and conversation and to see what he thinks. But either way, he has broken teeth that we need to take out. We need to plan something for him and decay so then his teeth don't start, breaking and having issues or pain. So.
Right. And I think, that's going to be life-changing for him. Whatever option he chooses, but if he does end up going with a full arch implants, it will be life-changing. Mm-hmm. And something that I want, maybe people who are new to implants, you don't have to be young in your career, maybe you're just new to implants in general, mm-hmm. is don't be afraid to just jump into it and get started. Yeah. Because at the end of the day, if you're taking the courses and you have, the equipment, or maybe you have support from another doctor in the practice, this is a very valuable option for patients. And people will appreciate that you're offering this in your practice.
Oh, for sure. I think just letting patients know what their options are. And it's, again, if you're just getting started, if it's your first few implant placements, obviously, pick and choose which ones you will do. But it's a very rewarding thing. Mm-hmm. It has its stressful moments like anything. But I think, prepping a crown, that can be more exhausting to me sometimes than doing an extraction and an implant placement.
Exactly. And I think, picking the cases that may seem like slam dunks, right? Like if it's number 19 or, just somewhere that has a good amount of bone, get started there. And my advice would be do it free-handed, do a lot mm-hmm. of your cases free-handed and maybe with the support of a mentor in the office when you're doing that. But get the feel of what the bone feels like when you're going through cortical and then cancellous. And then, it'll drop in, there's going to be, you need that tactile sensitivity. So that way, when you're working in an area later that's more complex, what you're feeling for. Yep. And, basically where you're going. Right. But
yeah, it's all based on feeling. And that's one thing that I actually kind of attribute a lot of my kind of success in getting to know implants and placing them so early in my career was my like hygiene background. Like we learned tactile sensitivity from like day one, like what something feels like I don't have to look in order to know what something feels like. And implants are very similar to that. So mm-hmm. going from, doing hygiene for 10 years and then placing implants, it was very almost like it felt like natural in a way. Yeah.
I agree.
Yeah.
Well, I think this has been very insightful about dental implants, Dr. Marsha.
Yeah, thank you.
And we're going to be back next week, and we're actually going to focus on a day in the life as a dental hygienist.
Thank you so much for listening. If you enjoyed this episode, please share it with a friend. Don't forget to leave us a comment, rate us, and subscribe so you never miss an episode. We appreciate your support and look forward to bringing you more great content.